Sir, Ravikumar sir, good evening, sir.
Good evening, Sandal sir.
Sir, Karthik Prabhu sir, good evening, sir.
Good evening, Inside sir.
Sir, வந்துட்டு இருக்கீங்க sir.
Yes,
Traveling.
sir, on the way, traveling, sir. No problem. I'm inside only. நீங்க எப்ப கூப்பிட்டாலும்
Yes, sir. Yes, sir. Just 2 minutes, sir. We'll start.
Take your time. Take your time, sir. No issues.
Anand sir, we will start, sir.
Yeah, Sandel, we can start.
Yes, sir. Okay, sir. Sir, Anand sir. Sir, Anand sir, ready, sir? We will start, sir. Meeting call to order. Anand sir, we will start, sir. Sir, kindly unmute, sir. Sir, not audible, sir. Sir, kindly unmute, sir.
Sir, I'm here.
Okay, sir. Anand sir, பேசுறது கேட்கல. இல்ல. கேட்கல. Anand sir, unmute பண்ணுங்க. Ask to unmute. So now we request Dr. Tirumurthy sir to give IMA prayer and Christian prayer. Sir, Tirumurthy sir. Sir, it is not audible, sir.
Tirumurthy sir, net connection is not all right. Tirumurthy sir, we didn't hear you.
Good evening, doctors.
Yes, sir. Audible, sir. Proceed, sir.
Okay. Physician's prayer. Dear Lord, thou
Sir,
great
IMA
physician.
Sir, IMA prayer, sir.
IMA prayer. IMA prayer. IMA prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure.
Sir, kindly proceed with the Christian prayer, sir. Christian prayer.
Physician prayer. Dear Lord, the great
Baba.
physician, I kneel before thee, since every good and perfect gift must come from thee. I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart, give singleness of purpose, strength to life at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guilt and worldliness, that with the simple faith of the child I reply on thee.
Thank you, sir.
Okay, sir.
Thank you, sir. Now I will be giving my welcome address. See, at this outset, I thank our State President, Dr. Abul Hassan, sir, our State Secretary, Dr. Karthik Prabhu, sir, our Senior National Vice President, Dr. Gunasegaran, sir, our President-elect, Dr. Senguttuvan, sir, Dr. Sridhar, sir, and all our senior state leaders, and our course coordinator, Dr. Ravi Kumar, sir, and our star speaker of the day, Dr. Narayanamurthy, sir, and all our CGP office bearers, and mainly the participants who have registered and enrolled for this CME. I welcome you all to this event. I hope we will have a good academic feast today. Our academic coordinator, Dr. Ravikumar sir, has already run this course for the last year, and sir will be sharing wonderful pics and representations. So kindly stay tuned on, and we will start with the session. Now I request Dr. Abul Hassan sir to give his presidential address and also inaugurate the fellowship course. Thank you, sir.
Thank you, Dr. Senthil Kumar. Good evening, all of you. Respected Honorable Secretary of IMA, PNSP, Dr. Karthik Prabhu, Finance Secretary, Dr. Gauri Shankar, National Vice President, Dr. Gunasegaran, President-elect, Dr. Senguttuvan and Dr. Sridhar, and my dear friends in CGP, Dr. Senthil Kumar, Dr. Tirumurthy, Dr. Ananda Chakalingam, and Dr. Madan Mohan, the faculties of today's program, Dr. Narayanamurthy, and the course coordinator, Dr. Ravi Kumar, and all members who joined today's program. I am very happy to see that IMA CGP is inaugurating or commencing our fellowship course on diabetic foot, and I am very happy to inaugurate it. You all aware that diabetology is one of the important course IMA CGP had done earlier with a huge volume of beneficiaries, and that thereby the diabetes care itself had enhanced in our state. Every nook and corner of state, people were there giving adequate diabetic care to the patients after undergoing this diabetology course by the IMA CGP. And I'm very happy again to know that there are about 80 candidates who joined diabetology course. It was inaugurated last time, and today also I am very happy to see that about 78 people have joined this course. And one more interesting thing in this course is we will have both online and also physical contact classes. And Ravi Kumar, who has been the expert in this particular field, will be conducting these courses. And you all know that diabetic foot care is gaining so much importance. It itself is a separate field called as podiatric surgery. And definitely, as the volume of diabetic patients increases in our country, the foot care gains so much importance. The number of people undergoing amputation, toe amputation, and below knee amputation is becoming very, very less nowadays because of much understanding about the pathophysiology of diabetic foot or diabetic gangrene. And the prevention is better than cure, all know. I wish this particular course will go a long way in prevention of diabetic foot complications. because of propagating the message about the diabetic care, the scientific aspects of diabetic food care. So once again, I wish IMA CGP all the best and all success in this new venture of fellowship on diabetic food care. And also I thank Ravi Kumar and Dr. Narayana Murthy for sharing their time, sharing their energy for the purpose of this great milestone development in IMSCG. Thank you very much for the opportunity. Over to you, Dr. Sindel.
Yes, sir. Thank you.
Thank you, President, sir. Sindel, am I audible?
Yeah, yes, sir. Yes, sir. Kindly proceed, sir.
Yes, sir. Sir, thank you, sir. Thank you for your kind words and the words of encouragement, sir. I now request our State Secretary, Dr. Karthik Prabhu, sir, to give his felicitations regarding this course and to inaugurate the course also along with them.
Thank you.
Karthik
Thank
Prabhu,
you.
sir. Thank you.
Thank you, sir. Most respected President Abul Hassan, sir, Chairman and Secretary of CGP, and the faculty, Vice President, and everybody, all leaders here. Good afternoon, good evening, everybody. So I really want to appreciate our President, because in this era of the increase in non-communicable diseases, apart from courses in CGP, like diabetology course, the foot thing and all, he's also made a committee for non-communicable diseases. And that committee is also getting very active and planning a lot of activities to control it. So that is one step which our president has taken, and I would like to appreciate him for his work and commitment for this cause. The second thing, sir, we have two important faculties for this course. The course on food care management, we have one senior plastic surgeon, Narayana Murthy, sir, and Dr. A.K. Ravikumar, who is the Hospital Board of India chairman. I would like to tell a few words about Dr. Ravikumar, because he's been senior to me in the Coimbatore branch. And when he was very active as secretary, there are many people who asked, how come Dr. Ravikumar has taken this post? Because until then, there was a notion that people who are busy will not be able to handle the post in IMA. And he was an inspiration for many, where he's conducted a lot of programs in this hospital earlier, even before taking an office bearership in IMA. And such a busy person, very involved in food care management, and he used to keep parties for them post after the training. He will do a lot of things he's done for food care. So none other than him can be the right person also to coordinate this. And my heartfelt thanks to him for perceiving this every year, because I've seen it through how it is so important and how he trains people practically and everything. So they're all pillars of strength for taking this course further. And again, Sindel sir and Anand sir, you've done a phenomenal job. This online has such a nice response. You're taking CGP forward in a very big way. My best wishes to you. And all the faculty and everybody, thank you and best wishes for this course, our support. Thank you, one and all.
Thank you, the State Secretary, sir, for your very, very encouraging words, which will make us work more hard and bring more courses into the right. Thank you very much, sir, for your kind words.
Thank you, sir.
Thank you, sir. So, and now I would like to say, as a faculty secretary of MSCGP DNSP, I would like to say a few words about our courses. See, actually, there are around 7 courses, amongst which this is the second course we are inaugurating now. Last 30th, we had 30th of January, we had the fellowship in diabetology course, where prior to the course, as Abul Hassan sir was saying, prior to the course, we had 21 registrations for the course. But after the response from there were around 1,600 views and more than 1,000 people who attended the course full time. So they have registered for the course, and it is now nearing nearly 70 registrations have been done. And this 25th, we are inaugurating the course. The direct class is going to happen at Chennai. So similarly, I hope this inaugural CME on food care management will take a great leap forward, so that there are around more than 600 registrations today itself, where people are have an idea like what is diabetic food care, who are the specialists who can take up this course. So I think that this will be an eye opener for them also. Similarly, we have the other courses. The next in line is next month. We are planning to inaugurate the fellowship in infectious diseases, course in infectious diseases. So we have got some registrations till now. So hopefully we'll find out this also. And in this platform, I would like to say a few words regarding this year. From this year onwards, we are planning to conduct a zonal CGP conference for every quarter. So probably next month, March 24th, the most probable date, we are planning to conduct as first the South Zone Ramanathapuram. So it will be a hybrid mode. People nearby districts and who all want to can attend. So and after that, it will be also in hybrid mode. So we'll give a short notice after informing this. So I now request our office bearer, Dr. Madan Mohan sir from Velur IMA. Sendil, can we?
Yes, sir. So now, yes, sir. So now we will go with the felicitations, and I request our senior national vice president, Dr. Gunashekhran sir, to give us felicitations regarding the course. Thank you.
Good afternoon, everyone. Respected State President Dr. Abdul Hassan, our State Secretary Dr. Karthik Prabhu, the Chairman of IMA CGP Tamil Nadu State Faculty Dr. D. Senthil Kumar, the Faculty Secretary Dr. Anand Chokkalingam, Dr. Tirumurthy, Joint Secretary Madan Mohan, and the today's course coordinators Dr. Narayanamurthy, Senior Plastic Surgeon, and our good friend Dr. Ravi Kumar, who is going to take up the course of diabetic foot as in a big way. Already he has conducted one session. So today we are inaugurating the next batch of diabetic foot classes. I congratulate the team of IMA.
Sir, not audible, sir.
Itself, we have more than 460 members participating in this meeting. That itself shows that the CGP's success in conducting this course and how it attracts many members. Especially, in many meetings, I tell our members that each and every member, basic MBBS degree itself is enough to have knowledge about diabetes. Because considering the population of diabetes, every member has to treat a diabetic patient. Similarly, all of you should treat diabetic foot also because it is an allied one. Only if you find some hemodynamic compromise or vascular disparity, at that time only you have to refer to a surgeon or plastic surgeon like that. So what you have to learn when you have to treat, when you should not treat, when you refer. These things I hope our Dr. Ravi Kumar will teach you in due course. I wish all the success for the diabetic foot course and also for the CGP office bearers. Thank you.
Thank you, sir. Thank you, sir, for your kind words. We'll keep up to your expectations. And at this outset, I thank our state president, secretary, and finance secretary for approving and upgrading the Zoom license from 500 participants to 1,000 participants. Really, it made a lot of difference for us in the last few CMEs. We are able to make the program hassle-free. And again, thanks to you, sir, and the entire state office. Thank you, sir. Now, I request our state finance secretary, Dr. S. Gauri Shankar, sir, to give us felicitations. Sir, not audible, sir.
Thank you, Senthil sir. Am I audible, sir?
Yes, audible, sir. Yes.
Yes. Most respected President Dr. Abdul Hassan sir, State Secretary Dr. Karthik Prabhu, National Vice President Dr. Gunashekhran sir, Faculty Chairman, CGP Chairman Dr. Senthil Kumar, Secretary Dr. Anand Chokkalingam, and all the Joint Secretaries Dr. Tirumurthy sir, Rajesh Sengudan sir. Good evening to everyone. And as we told in all meetings, So this CGP's chapter is going on very well under the leadership of Senthil Kumar and Anand sir. So we congratulate the CGP state office bearers for conducting the program so well. So this is a big success for our CGP chapter, as there are already 70 registrations for the courses. So as we have already talked in the previous meetings, conducting courses is the important thing for our CGP course, not CMEs. So the conduction of we are concentrating more on conducting the courses. So as of now, it is a big hit now. So 70 is a lot of registrations. Hats off to the CGP chairman and the secretary and also joint secretaries. They are really working hard and they are showing the potential to the whole IMA community. So I'll congratulate you for conducting more courses as Dr. Anand Chaklingam said. So we are going to plan on infectious disease courses. So we have to tell a lot of people about that and all branch presidents and secretaries to have a lot of registration on that course also. So you are doing a wonderful job. Congratulations for your good work. And also the selection of people for conducting CM is also very good. Dr. A.K. Ravikumar sir and Narayani Muthu sir are all the pioneers in this field. So I congratulate all of them and best wishes for running the courses. Thank you for the opportunity. All the best, sir.
Thank you, sir. And also, we also come to the same point that we will be conducting the CMEs only along with our course inauguration. So our entire focus is on the CGP courses. And thank you, sir. Thank you. So now we will move on to our CME session. Now I request Dr. Madan Mohan, our CGP representative, and Dr. Tirumurthy sir to coordinate the CME. I request Dr. Madan Mohan sir to introduce the speaker, star speaker of the day, Dr. V.R. Narayanamurthy sir. Madan sir, kindly proceed.
Sendil, before that,
Yes, sir.
Dr.
Yes, sir.
Sridhar, President-elect, also can have.
Yes, sir. Fine, sir.
I think is
Yes, sir.
joined.
Yes, sir. Sure, sir. Sridhar sir, now I request our President-elect Sridhar sir, who is also in the meeting, to say a few words about this CME and the fellowship course inauguration.
Thank you, Abul Bhai, for recognizing my presence, and thank you, Sandil. I think this is a day of extreme happiness for IMA that we are inaugurating a course with 70 candidates. We are getting back to the glory of those days when Jailal used to be the CGP state secretary, and we used to have hundreds of students enrolling for diabetology, and we used to have a grand convocation for diabetes candidates. And we can see across Tamil Nadu, a lot of people doing diabetic practice simply out of their empowerment they got through CGP. So I'm very sure now we have got more specialized with diabetic foot care. And I think no other person than Ravi Kumar is a fit person to teach us, guide us through this diabetic foot care, because he has been doing enormous service all through in this department of diabetes. And I am very pleased to note the presence of Dr. Narayana Murthy, an eminent plastic surgeon. I think together these two can make a very big impression on the course. And I'm very sure whoever has joined the course will benefit immensely. I congratulate the State Office of President Dr. Abul Hassan, Secretary Dr. Karthik Prabhu, Treasurer Gauri Shankar, the team of CGP office bearers, Senthil, Anand, Madan, Tirumurthy, and the rest of the people who have done an immensely popular work today, and later years to come as infectious disease. As you said, you are going to have another course on that. I'm very sure IMA is now on an aggressive path of improvement, and both academic and association activities under the guidance of the current president, Dr. Abul Hassan. I wish the course all success, and thanks a lot for giving me an opportunity. Over to the CGP.
Thank you, sir. Thank you, sir, for your kind words. And also, we'd like to add a point. For the last diabetology course, we have 70 registrations, and the course is going to commence tomorrow. And for diabetic
Yes, sir.
food, we have 10 registrations, and we are expecting at least 30 to 40 before we commence the course. Thank you, sir.
No, no, after the end of this today's session, I think you will hit 70 in this also.
Yes, sir. Thanks, sir. Hope it happens. Thank you, sir. Thanks. So now we start with the CME session, and I request Dr. Madan Mohan sir to introduce the speaker.
Good evening, everyone. I'm very happy and privileged to introduce the senior most plastic surgeon, Dr. B.B. Krishnamurthy, B.B. Narayanamurthy sir, who is going to talk on diabetic food basics to clinical practice. Sir, we welcome you, and we are very happy to have you on this forum, sir. We are Professor Dr. V.B. Narayanamurthy sir is a senior consultant plastic surgeon who did his MBBS from Stanley Medical College from 77 batch. He did his Royal College of Physician and Surgeon Glasgow FRCS course in 1984 to 1990, and he started his plastic surgery course from 1990 to 1993 onwards from the British Association of Plastic Surgeons and Royal College of Surgeons of England. Imagine he has started plastic surgery from 94, that is almost 30 years back. He started plastic surgery in the country, and he has been practicing sincerely. So he has conferred Sushruta Professorship of Plastic Surgery, but Icoplast in 2019. So he has various publications. PCT application for co-inventor in pedopograph jointly with IIT Madras and Southern Medical Foundation. A patent for healing footwear in diabetic foot. He had patent for prevention of ulcers in diabetic foot. Lot of patencies, like many patencies he's got in diabetic foot. And his additional professional activities in endoscopic plastic surgery and emerging field. He was the first person to present us in the only experience in India on use of endoscope in the harvest of rectus abdominis muscle for reconstruction of the Indian Society of Reconstructive Microsurgery. He has a elite memberships, professional membership. Is an executive member of the Indian Society of Surgery of the Hand, life member Association of Surgeons of India, is a life member of Association of Plastic Surgeons of India. He was a president of Diabetic Foot Society of India, life member of IMA, life member of Madras chapter of Otolaryngologist, and life member of Chennai chapter of Plastic Surgeon. Sir, we are very privileged and happy to have you, sir. Welcome you, sir, and we request you to go to your presentation. Sir. Thank you so much.
Thank you. Thank you very much. Can I have the first slide?
Yes, sir. Very good.
Can you all hear me? Is it clear?
Yes, sir. It's very clear.
Yes, sir. Very much, sir.
At the outset, let me thank Dr. Ravi Kumar for getting in touch with me and asking me to talk on a topic which is very, very dear to me. Though I'm a plastic surgeon, I moved on to do a lot of work on diabetic foot. Thank you, Dr. Ravi Kumar. Thank you, Dr. Abul Hassan, for inaugurating this show today and then making it very worthwhile for all of us to participate. I'd like to also thank the incoming president of CGP, Dr. Sridhar, who spoke to us just now. And I'd like to thank everybody else before I start this today. So can I change the slide myself, or yeah? Okay. I can actually share my slide if you want.
Yes, sir. You can share, sir.
Shall I try that?
Yeah. Yes, sir. Yes, sir. Please do that, sir. I will stop share.
Yeah, stop it.
You can share it, sir. I think you have that option.
I have shared it, yes.
Yes, you can do that.
Is it come?
Not yet, sir.
Not yet, sir.
I have shared it actually. So does it come?
Not yet, sir, not yet. Shall I do that, sir? Otherwise,
Please. It says I'm viewing Ravi Kumar's screen. I should actually.
yes, sir. I think.
Sir, we can maximize the slides.
Yeah, I'm doing that.
Okay.
It's not getting. You please go ahead, sir. I will just.
Okay. So today what I'm planning to do is a mixed crowd, which is always a very useful crowd to talk to, because as I said, and again, as you all mentioned today, diabetic foot is not restricted to one specialty. It's actually a specialty which spans all the different groups, starting from GPs. And can I have the second slide?
This one, sir. Statistics.
No, before that.
Yeah.
Yes. Right. So what I'm planning to do is to give a very day-to-day management, practical things which we had to do, but also it has to be evidence-based, and hopefully it will be an interactive session. So to next slide, please. So to define a diabetic foot, actually defined as wounds which happen below the malleoli, but there are exceptions to that because most of them can spread above, so we can't exclude. So for main purposes, it's taken as ulcers in the feet below the malleoli. Next slide. Next slide. Okay. So what is that we need to know? The three things we need to know is, one is the numbers. We're not going to the details of the numbers, but we all know that the numbers are rising alarmingly, and each one of us have to have something to do to prevent it and also to and mitigate the complications. The potential dangers are that we know that the poor glycemic control and other sides, risk factors can actually make sure that these people can be prevented from going into the complications. The worst thing is, whenever you have a diabetic patient, the overall well-being is actually lost. Their ability to walk, do day-to-day work, and then the ability to take care of the family, all these things are really affected. So it's not a simple thing when they have even a small ulcer. Next slide.
Spectrum.
Yeah. So if you can just click on the spectrum.
Yes, sir,
the day you do the
slide is
go to slideshow, please.
Yeah, that is not getting open, sir. I'll do one thing. Slideshow, it is not responding actually.
Okay.
Should I go to the next slide, sir?
Yes, sir, please. So basically what we want to see is that one third of these patients actually develop ulcers, and half of them become infected, and 20% of these get amputated. And the good news is that barefoot walking and the old traditions, if we can have some sort of a control on these things, we can actually mitigate this problem. So if you say one third of them only develop diabetes, then is it mine? Nothing. Yeah, I got control now. So.
Okay.
So.
Are you able to do that, sir?
I think so. I think so.
That case, I have to go.
1 minute, sir. Let me see. Can you see my screen?
Not it, sir.
One minute. Sir, you can put my slides, sir. Let me go through it because I'm
Okay,
not
sir.
able to
No
share this.
problem.
I don't know why. I don't know why.
No. Yes. Yes, sir. Is it
Okay.
visible now? Yes.
Now it's visible. Yeah. So
Yes,
now
sir,
you can
yes.
see, I think so the moment you
Ah,
keep clicking, sir, when I say.
yeah.
So the moment you are
Okay.
diagnosed as diabetic, the complication starts going, and I preferably like to divide the diabetic foot as a 3 different spectrum: pre-ulcer and ulcer and post-ulcer. And then all of us are involved. In the pre-ulcer stage, I think most of the general practitioners, diabetologists are involved. Ulcer stage, mostly the surgeons are involved, and the medical treatment of ulcers are involved. And post-ulcer, this patient actually goes back to pre-ulcer stage. So they actually become pre-ulcer but at risk. So this is what we need to understand. Next slide, please. So this actually goes in some people, the progression of the disease happens very slowly. In some people, it happens very fast. Next slide. This again, I went through. Again, the onus of treating these patients is predominantly on the GPs. As a plastic surgeon, on the top of the list, we actually come up very late, and it's only the 20% of them who get amputated, but a huge amount of them have to be treated properly so that they don't go to this stage. Next slide. So what is that the GPs and other people have to do? One is they need to know who is at risk of developing ulceration. Second thing is, once the ulcer happens, who are the people who will have the risk of having complications? The third thing is, after an amputation, how is it that we can make sure they don't get problems with the other foot and also other toes? So this is the most important thing. Next slide. So this is what I'm going to talk about. So the pre-ulcer stage, we have to make sure that they don't develop ulcers, which means, a patient may look like this. But what are the factors which we had to pick up so that he doesn't develop ulceration? Next slide. And the ulcer stage, you can see they can be treated in so many ways. Post-ulcer stage, again, as you can see, this patient had successfully had a treatment of an ulcer, but very disheartening to see that they come back again and again. And lastly, if the patient has had an ulcer on one leg, it's a 50% chance that they can have a further amputations on the other side or other toes. Next slide. And right now, diabetic foot complication is the major cause of non-traumatic amputation. Though we have a lot of accidents and other cause of injuries to the foot, the most common cause of amputation is still the diabetic foot complications. Next slide. So who should look at? Again, let us go to the evidence-based. International Working Group says that the diabetic foot can be looked at various places, at the GP stage, at the secondary care level, the tertiary care level. This is, I'm putting it just for the completion's sake. Now, this may not work in our country, but I think we should know how this has been described. So level 1 is by general practitioners and diabetic nurse. Level 2 is various other people. Level 3 is like specialized centers. Next slide. Now, let me come to you. I just put this slide because we may not be practicing like the West. Okay, so we don't have a system where the patients can go like that. So I said, what is it the GP should know when he's confronted with the patient who's got a diabetic foot? I said there are 3 areas: pre-ulcer, ulcer, and post-ulcer. You also see these patients. You should also read them well. But let us see what are the various things we have to do. So once you see the patient, the first thing we had to do is we had to make decisions about what are the types of imaging we had to do, what are the type of antibiotic we had to use, which is again the GP's domain. What is it we had to do as a surgical treatment, incision planning, which is not your domain, but I think it's very important. You should also know. I'll come to the research later. Wound management, very important. That a diabetologist and a GP should also know how to treat a wound properly. Reconstruction diabetic foot, again, you have to know what is available so that you will know, as somebody has said this just right now, you should know when to stop, when to send, when you should not do things. So these two things are important. GP's awareness about incision planning, and GP's awareness of reconstruction, but all the others are in the GP's domain. And I think I will try to see justice to provide very basics of all these things in the lecture today. Next slide. So first thing you have to do is when the patient comes, you have to do a foot examination. So what does foot examination tell us? Next slide. So foot examination tells us that, very important, more than 50% of the amputation of the leg are due to diabetes. I told you that. All of us actually see, look at the eyes, kidney, look at heart, you will get an ECG, you'll get an echocardiogram, everything else. Very often foot is not inspected. Why is it not inspected? What will happen if you don't inspect this? Next slide, please. So what happens is, it is very important you should examine what to examine, how to examine, what are the things you have to recognize, right? So importance of examination, method of examination, awareness and recognition of the common problems. And most importantly, don't forget that you should also look at the footwear he is wearing. Next slide. So importance of foot examination. Not all people with diabetes develop foot ulcers. This is very important. Not everybody with diabetes will develop problems. But in many cases, serious problems can be prevented by understanding what happens to the foot and how to take care of them. So this is the most important thing. You don't have to examine the foot at all, right? So the most important thing by looking at the foot just for a half a minute or 1 minute is that you can identify the foot at risk, because that's the most important thing which you have to recognize. Next slide. So there's a quick and easy method of examination which will be very useful. And what is it that the American Diabetic Association and also the Diabetic Foot Society of India tells you to do? So very simple things. Next slide. First is you have to know 3 things. We all know about all these things. Whether we can find out the patient has got neuropathy, whether the patient's got vasculopathy, whether he's wearing the footwear, whether the patient has got infection or the sequelae or precursors of infection. So these are things important. Next slide. Next slide, please. So these things, the combination of these things causes. So before going to those things, we have to understand the 3 most important things. The vasculopathy, which is very important because that gives life to the foot. Neuropathy, which actually protects the foot. Immune dynamics, because of glycemic control, the patient's immune system becomes less. So therefore, clinically, we have to make sure the patient has got a good sensory foot, good vascularity, whether there is any early signs of infection, which if we don't look at it in the initial stage, can progress and cause various problems and complications. Next slide. So first, all of you may know that Semmelweis-Stein is a not a very good test, but some test to do. You have to make sure that the patient has got sensation or not. There are various other tests, but this is one of the simplest tests we can still do in the outpatients department. If you don't do that, you can do what's called a very simple test, where just ask the patient to see if he recognizes the finger touch in at least 3 or 4 toes. If it doesn't, then that calls for further test. Next slide. Patients, you may have to feel the pulse. If the patients you may not be able to feel the pulse in some people because it may be calcified. There may be flow. Patients can have thickened vessels. As you can see here, this X-ray of a patient shows calcified vessels. So if the vessels are not palpable, please look for skin and nail changes and other changes, which will give you a clue as to the patient has got vasculopathy. Next slide. So early vasculopathy detected. You can do a simple ABI, which is very useful. All of you know. Next slide.
Mild.
Now, this is most important. We told you the third component, neuropathy, vasculopathy, third component is infection. Do not ignore any of these things. These are the early signs of vasculopathy. It can be sign of neuropathy. And these are early changes. They can be skin cracks, nail pathology, web space infection, and deformities. So this don't ignore. This patient has got, it may look simple. You may just give some creams and send him away, but these people have to be evaluated because he is actually representing immunodeficiency. Soft tissue changes, as I told you here. Next slide. Soft tissue changes, look for web space infection and treat them properly and educate them. Next slide. Now, this is very important. Whenever a patient comes to you with just a small redness in the foot, please do not ignore them, because any redness in the foot is a indication of a deep-seated abscess or deep-seated infection. Next slide. Anybody who has been coming to you with, let's say, a small ulcer, suddenly if he comes with a foul-smelling ulcer, it is an indication that there is a chance of osteomyelitis. Please take an X-ray. Don't ignore them. Don't just start him on antibiotics. They may be having osteomyelitis, which you can prevent, or you can prevent further complications. Next slide. Now, anybody who comes, as I told you, this patient who came, he had an IND done, but he had infection. Second day, third day, he developed this sort of an infection and gangrene. So never just do an IND in these patients. They need proper evaluation. Next slide. So think, next slide. This patient, again, importantly, see this patient had, if you look at the foot, the patient does not have any infection. This patient had vasculopathy. He had everyday small debridements, and one fine day, as you can see, there's a small thread in the one side. He had a small bleeding. The surgeon or the person actually sutured the wound, tied it, and therefore this potentially salvageable foot has gone into below-knee amputation. So do not do things which you're not clear. Next slide. Now, classification is very important. I'll just go to mention here. Next slide. There are various different types of classification. I'll go into the detail later because it's very, very important. As a group, now we have over 600 people, all of you seeing. The one thing India lacks, which as a president of Diabetic Foot Surgery, I've been trying to push, is to see how each of us can actually record these things. I'll give you a simple method at the end of the class, but this is for your understanding. This is a Western understanding. Basically, these things tell you how much of infection is there, how much of vasculopathy is there, where it is, but it does not tell you about the patient itself. Next slide. So be aware of it. You may be able to use any one of them, but see that if you can use something, we will become a very big power in the world if each one of you can have some sort of a documentation. Next slide. So these are the different types of classification systems. I'm not going to the detail, but it is useful to know about all these things. Now, the most important thing I would like to actually stress upon is we had to break the myth saying that diabetic foot will take a long time to heal. Everybody, patient comes and says, doctors comes and says, but this is an important piece of literature which I always follow. This is by Peter Sheehan, who was an American Diabetic Association president long time back, and he put up this paper, and it's a very useful thing which I follow. If you look at the wound, and if in 4 weeks time, the wound should actually reduce by 50% area. So percent change in the wound area of diabetic foot ulcers over a 4-week period. If that is happening, then you can say that this particular wound is going to heal. I would say that, to me, what I found is if you can look at the wound every day or whenever you are dressing, see that the size of the wound is becoming less. In 2 weeks time, if you find there's a significant improvement, then you can go ahead with your conservative management or treatment, or you can say, I am treating it well. If after 2 weeks, 3 weeks, 5 weeks, you find that the wound is not getting better, you can be rest assured that this wound is not going to heal in a proper way. So this is very important. So temporal relationship is important. And with this, I would like to give you a few small different types of classification, which I would like to all of you to know. Next slide. So this is a patient who comes to you. This wound has happened only within the last 1 week or so. So this wound can be, and I call it an acute wound. So this is an acute wound which has to be treated very, very aggressively. This is a toe-threatening limb or toe-threatening wound. Next slide. Next. So this is a limb-threatening wound. All these have happened only within the first 1 week, 2 weeks, 3 weeks maximum, or 4 weeks. Next slide. Now, as you can see, this patient has had a below-knee on the right side. He's come with another infection. He's not only a limb-threatening, but he has got ARDS, so he can be life-threatening. So this is an acute situation. When the patient has got an acute situation, we have to act in an emergency situation. Next slide. Time is important. Next slide. Now, this is another example. All of you would have seen people coming with a small. This is well beyond 2 months or 3 months. Again, there's being dressed every day. As I told you before, please look at the time period. If the wound is not healing in about 3 weeks to 4 weeks time, always remember there's something deeper inside and that has to be treated properly. So I call this subacute infection. So next time when you see a patient who is not healing in 6 weeks or 5 weeks time, please rethink and then do something about it. Next slide. Now, this is all of us would have seen these patients who are having these ulcers for 6 months, 9 months, sometimes 8 years. I had patients. Now, these are chronic. They can be chronic infection. They can be what is called chronic, non-infective, non-healing wounds. So you have to, the day you see first time, you have to define what sort of wounds they are. Then only you can go with the treatment. So these are potentially infections which can become infected. Next slide. Now, these are a lot of things. This is not yet an ulcer, but I call it a potentially infected wound because there will be a small ulcer in the deep area. And as you know that whether it is Coimbatore or Madras, after a bout of rain, the water is basically sewage, and then you'll find a lot of people coming with infections. So these things, this cannot be ignored. These things can go on for about 6 months, 9 months. You may be treating it with shavings and all that, but they are potentially infective wounds. Next slide. Now, this can be recurrent. People will come with these wounds, they come infected again, they get better, they go back. 6 months later, they become infected. So next slide. So I call these people as acute on severe chronic infection. So please date the timing. If you find the patient has got shorter duration, they had to heal faster. If the patient has been having some sort of subacute infection, they had to be looked into very carefully. Chronic infection has to be treated appropriately. Next slide. So I told you about various classifications, existing classifications. They all classify ulcers. They don't tell you the severity of the thing. They don't tell you the urgency, and they don't tell you the treatment options. So these are all the classifications are important to document these cases. Next slide. Now, so I told you about a foot examination. Next, we come to imaging in diabetic foot. All of us know that it's very important to image this. Why do we have to image? Image if you have a toe or a toe gangrene or even a soft tissue injury, you had to know what's the status of diabetic neuropathy, vasculopathy, infection, and a combination of all these things. Next slide. For all these things, you have to go through a standard set of guidelines, and which will actually help us in various ways. So we have to know how is that going to contribute greatly in the diagnosis. Is it going to delineate infection? How is it going to monitor the progress of treatment? And we can plan subsequent reconstruction. So value of imaging is to see one or all of these various parameters we have to know about. Next slide. So what is the ideal imaging technique? I would think this is an ideal image. Can you imagine if you have possibly a color imaging system which will give you exactly like what it looks like? We still don't have it, right? So all we have to do is we have to look at images which is in black and white. We need people who have to interpret them, which has to be easy and has to be cost effective. So imagine you have an image like this and it tells you there's abscess, there is vascular thrombosis, there is collapse of the bone. So we still don't know. So till that comes, we need to make sure that we have as much information from the particular imaging modality, and whether it is cost effective, whether it can be reproducible. Next slide. So then we have the various, what are the modalities? We have the various modalities available. We have to be very judicious about the use of these modalities. And I'll tell you how we can do that in a short while. Next slide. So this I told you, a patient who has come, very simple patient has got an ulcer for a long time. Suddenly he starts having a slight discharge. You have to be aware of a skeletal involvement. You need to get a small plain X-ray, which will actually give you enough information about giving you the details about osteomyelitis. Next slide. So here again, this patient has already had, calcified vessels. So we need to know further. Then we have to go for further modalities of findings. This may be an accidental finding in many people. People who have come for routine examination, who's got a small ulcer, you'll find you take an X-ray, they may have thrombosed vessels. Thrombosed vessels may not be bad because they may still have a good flow. Next slide. Ultrasound has got as you know, ultrasound got a very limited value in diabetic foot. It only does two things. It is very useful for vascular studies, and it is useful for delineating abscess. Bone again, CT is again very useful only to look at bones. It doesn't give you much of information about soft tissue and all that. Next slide. So where do we go about? So I'm just going to go through, please go through this American College of Radiology, what is called American College of Radiology appropriateness criteria. I'm not going to the details. If you want to do the various modality of tests on the left side, you'll have to know which is the best modality. And as I said here, for radiography of the foot to find out bone, X-ray itself is good enough. And I think you can ask your radiology colleagues to give you the best modality of treatment. So these are the various things are available, and we had to know which is the best modality of imaging for that particular condition you are looking at just in front of you that particular day. It has to tell you the condition today. It has to help you to plan the procedures. It has to tell you whether you can repeat it for seeing the progress of the problem. Next slide. So I'm not going to the details. These are, again, I mentioned this for completion studies. I have never done that. This is only for finding out whether the patient has got difference between osteomyelitis and Charcot disease. Very, very difficult. I don't know many people do them, but for completion, I mentioned it here. Next slide. Angiography, very useful for vascular studies. Very, very useful for preoperative modality of imaging in ischemic foot. Next slide. MRI, again, it's a very, very useful tool. We can pick up very early osteomyelitis. You can pick up early changes in the bone marrow even before the cortex is involved. Here you can see the patient has had a small ulcer. He came with swelling, small discharge. X-ray did not show anything, but MRI showed huge abscess and collection. Treated him with the conservative management and antibiotics. He healed. So it's very important to know how to use the right sort of imaging technology. Next slide. So whether it is plain X-ray, MRI, you have to take into consideration the cost. You have to take into consideration the future modalities you may have to use, and please make sure that you take the right imaging technique. Next slide. So next I told you is after imaging, the use of antibiotics, infections in diabetic foot. There are again guidelines from the International Working Group and from Diabetic International Infection Society. Most important thing is you had to find out whether the patient has got three things: whether it's got mild infection, whether it has got severe and moderate infection, or severe infection. So again, I'm not going to the details. Rest assured that small mild infection is when you have a small erythema, small redness and tenderness and warmth, very little pleural discharge. These patients can be treated as mild infection. Next slide. Then you can have moderate infection. You can see that the wound is becoming bigger. There is a lot more discharge. And then severe infection is when we have patients who have high fever, respiratory complications. Now you can add moderate, severe, or mild. If the patient has got osteomyelitis, you add O to it. So you can say mild, moderate, severe with osteomyelitis, without osteomyelitis, because that changes the treatment of these patients. Next slide. So emphatic use of antibiotics. Next slide. So diabetic foot are generally severe and more difficult to treat, especially if the patient has got vasculopathy. And this is one of the very good journals you have to, if you want to look through, by Kunha, Antibiotic Selection of Diabetic Foot Infections. I'm not going to the details. For people who want to know more, please read up a couple of these articles. Next slide. Again, Kunha antibiotic selection is very important. The consensus is that you should have a broad spectrum antibiotic, should be capable of covering most of the common pathogens found in diabetic infections. Next slide. So again, mild, moderate may vary from area to area. Lipsky is a very big name. He has brought out criteria on how to use empirical antibiotics. Next slide. Whenever you have osteomyelitis, the question is whether you want to remove the osteomyelitis segment or not. If they are small and they're not causing much symptoms, it may be possible that you may be able to get away with just long-term antibiotics. So that's again a very important clinical judgment you have to make. The biggest problem is MRSA. If you're not very careful, you can get MRSA, and then we get into a cycle of having more and more to treat and difficult problems. Next slide. So again, just to quote our own data, Vijay Viswanathan has published in 2002 their own study. Again, you'll find that it's a mixed organism we found here. It is a combination of Enterobacteriaceae and also Clostridium species and anaerobic sometimes. We don't actually do anaerobic cultures. but there will be a lot of anaerobic organisms. Next slide. What we did in 97 to 2003, we thought of doing our own. We looked at our own prospectively collected data. Next slide. Because I think we need to know our own. So we found that a lot of them were actually, again, enterobacteria species, staph, and strep also. Next slide. And G and B, we had C. coli, Klebsiella, Pseudomonas species. Next slide. We also did our antibiotic things, and we found that most of them were actually sensitive. Next slide. So it is important to have some guidelines on how to use empirical antibiotics. So if you have a mild infection, I think cephalexin is a good enough. If you have a beta allergy, you can start with clindamycin. I think most of us do follow this principle in India. Next slide. If you have a moderate infection, you can have a combination of beta-lactamase inhibitors if they are gram-positive or gram-negative. If you have MRSA, think about using vancomycin, which is sometimes possible. If you have ESBL, which sometimes we do see, mostly after hospital-acquired infection, we may have to start them on meropenem or imipenem. Next slide. So empirical antibiotic in mild, again, you have to know how long to give, how to give. If they are mild, you can get away by giving them oral antibiotics. If they are severe, you may have to think about IV antibiotics. And if you have bone resection, and if you have dead bone, you may have to think about treating them at least 6 weeks, sometimes up to 3 months. So these are the things given to follow empirically. Next slide. So conclusion, do not treat uninfected foot ulcers. As I told you, please see if the patient has got non-infected, non-healing wounds, they do not require antibiotics. If they need systemic antibiotics, they had to be treated very aggressively. And then if they need treatment surgically, they had to be taken up at the same time. Next slide, and early. Now coming to the treatment approaches, I think we need to have 3 things: strategies for effective care. It's as I told you, it's a combination of medical, surgical, wound care, which is very important. And the other thing is you have to make sure the patients have got associated care like foot care, making sure that they are adhered to proper diabetic treatment, and orthotics and occupational things. So these are it actually involves a whole lot of things, but I'll go through simply very quickly some of them. Next slide. Next slide. Next slide.
1 second, sir.
Yeah.
Ah.
So this is what I told you. So I told you that the GP's concern is actually in the initial management, antibiotic management, wound management. But it's very important they should know what a surgeon thinks and what he does. So the role of incision planning on infection eradication and wound conservation. This is an important topic which I think every non-surgeon should know. Next slide. So this is very important. Spread of infection, incision planning. So initial incision which you place is very important, and that had to be based on the goals of what you want to do. They had to be strictly based on principles of making incisions. I'll give you some examples. Next slide. Yeah, please go on. Keep going. So infection actually spreads, as you know, from the tip to the tip. Yeah, keep going. Keep going. So it spreads along the tendon sheath. So let us say, for example, you have an infection in one part of the foot. Next slide. So let us say you have an infection. It's very common. I showed you. You had an infection on the base of the fifth metatarsal. A lot of people are sitting down. They have callosities in the fifth metatarsal, and suddenly one day they come with an infection, and then you'll find that the infection will travel along the peroneus tendon. Similarly, the infections in the big toe and the ball of big toe, they're very prone for spreading along the flexor hallucis longus tendon. So any infection or any wound in the foot, they are basically associated very closely with the tendons, and any breach of the tendon and contact with the infected part can produce spread of this infection. So the spread can be in the plantar area. Next slide. It can be from one area to another. It can be from the distal to proximal. It can be from side to side. Next slide. Okay, so this is proximal to distal. This is from side to side depending on the muscles. Next slide. This can be from the bottom to the top. So they can actually, they can travel in very, very various ways. And this is the problem. Next slide. It spreads in layers. So as you can see here from the proximal, from the wall of big toe, it can just go right up to the flexor retinaculum. Next slide. So medial to lateral. So we also have to know what are the common areas. Why? Because the common areas are the most common areas where they actually have complications. So next slide. So for convenience, we divide the foot into 10 areas. So let me give you some examples here. Next slide. So here is an example I told you before. As you can see here, this is a small ulcer at the tip of the toe. But if you just amputate, the patient will come back because the toe is in contact with the flexor tendon and the extensor tendon. 3 to 4 days later, you'll find the patient has got a small ulcer in the middle of the foot, and then he'll develop spreading infection. So this has to be treated. The planning of incision has to be done in such a way that you can actually have access to the plantar and the dorsal at the same time. You can get access to the bone, you can access to the tendon. Make sure that you avoid all the neurovascular bundle, but at the same time, make sure you get a thorough debridement. So this is the whole thing about surgical planning of incisions. Next slide. Next slide. So you'll find there's a small ulcer. A lot of people come with a small pinprick or a thorn prick. Recently, we had a patient who has a thorn prick, and then you'll find that the whole transverse area becomes inflamed. So this is because infection has not gone very deep, but it is spread along the transverse metatarsal ligament, and this has to be very, very meticulously debrided. Next slide. Now here, as you can see, a patient has just got a small ulcer, but there is bogginess and swelling all along the foot and also along the medial malleolus. This has to be treated very, very carefully because this has got spreading infection. Next slide. As you can see here, this patient had significant infection right up to the flexor retinaculum, and a thorough debridement made sure that this fellow's foot is saved without further complication. Next slide. Next slide. Now, as I told you here, as a small wound going on for months. So always find out the time duration. If the patient has come to you today and he says he's got this infection for about 9 months, 12 months, patient has been taking antibiotics, be always sure that there is something underneath happening. This patient had a very small ulcer. You can see when I probed, there's a huge opening. Next slide, please. You can see that the patient actually had a large cavity, this huge cavity in contact with the calcaneum. So unless you treat it, this is not going to heal. So once you treat it, this patient will actually heal in 5 days' time, just like any other acute wound. So you had to convert a chronic wound in an acute wound. An acute wound will actually, if treated properly, heal in about 5 to 7 days' time. Next slide. So in conclusion, what I would like to say is whenever you are faced with the problem of a suspected infection in the common areas of the foot or areas that are in contact with the tendons, be sure that you get this help of a surgeon, and the surgeon should know the ability to make sure that the thin incisions are made properly, especially when a plastic surgeon gets involved subsequently. If the wrong incision is made, then it compromises the flap using flaps for these patients. So it's very important that you know all these things. Next slide. Next slide, please. Surgical treatment. Again, as I told you, temporal. So you have to find out what you're dealing with: acute, chronic, subacute, potentially infected, recurrent, and trauma and death. Don't forget, patients of diabetic patients have come with trauma. Next slide. And you'll find that a lot of these patients, again, quickly go through this. I'm going to just show you the flaps here, as you can see. Yeah, please go through again. This is again a small wound in the dorsum. Acute wound, they should heal in about 2 weeks to 4 weeks time. If they don't heal, then you're in trouble. Next slide. So this patient had a small injury, treated within 4 weeks time. This again, huge injury up to the knee, but treated within 3 to 4 weeks time. Next slide. Again, okay. Now this patient had injury. So this again, as I showed you, a small wound, more than 6 months. Next slide, please. Something happening underneath. Don't ignore. This tendo Achilles is in contact with the wound, is infected. Next slide. So you can see how we plan the flaps. We raise the flaps, did remove the dead tissue. Next slide. and then closed it on the same day. Next slide. In 5 days' time, it will heal. So first dressing which you see on the 5th day to 7th day, they'll heal. Now potentially infected, as I told you. Next slide, please. Potentially infected. These patients, if you're not treating well, they'll actually become infected. Next slide. Now, all these wounds can primarily be treated with flaps. So that's what I think, as general practitioner, you should know how we treat ulcers, because we have the ability to treat them primarily. As you can see here, this patient was treated within about 2 weeks' time, the wound will actually heal. The ulcer is removed, offending problem underneath, the bone is corrected, tendons are corrected, flaps are raised, and then they're closed. The problem now is to make sure they don't re-ulcer. Next slide. Next slide, please. I showed you that patient who had, this patient had a abonia on the left side. This patient had a huge ulcer on the calcaneum on the right side. He'll end up with a belonie, but this can be saved with a local flap and skin grafting. Next slide. Don't forget trauma in diabetic patients. As you can see, this patient, very common. We find people hitting against the door or something, has had a small fracture and a small wound. Been treating with dressings for about 6 weeks or 8 weeks. Next slide. We took an X-ray and we found there's a small sequestrum. Next slide. And once we remove the sequestrum, the patient actually, it'll heal fully. So once you know what's underneath, it'll heal. So anybody who is having a problem for more than 4 weeks to 6 weeks. Trauma in diabetic patients, very common. This patient had a trauma, being treated with, he's had a K-wire fixation, he's had multiple antibiotics, sepsis. You can see that his fever is around 104, 105. He's had multiple antibiotics, he's had a fungal patch. Ideal candidate for belonie amputation, because they'll say this patient is going to die, do a belonie amputation. Next slide. So this is still an acute infection. If he comes to the right place, as I told you, it's very important that the patient had the right treatment. All we do as plastic surgeons is debride. This is the example of a good debridement. You remove all the dead tissue, but also as much as possible all the bacteria. Next slide. And then we cover it up with a flap. Can you see there's a latissimus dorsi muscle flap? The patient went on to heal completely and then is weight bearing. Remember that this patient has got a sensate foot. The entire plantar skin is sensate, nerve is okay, only thing is dorsum is gone. He should not be getting amputated. Next slide. So in summary, that very important to know the time. Time is important. You can't just say it's gone forever. Acute to subacute happens because of persistent infection. The patient, the wound does not heal in about 6 weeks to 4 weeks time, it goes on to subacute and then it goes on to chronic. So it's important that you know what's happening. Next slide. So infection should be controlled before reconstruction. Not going to the details, but obviously if there's infection, we cannot reconstruct. Next slide. So as a plastic surgeon, we can start using a simple skin graft to a most sophisticated microvascular reconstruction. And the most important objective is to find out the patient has got a nice intact skin. And that's important. Next slide. I'll very quickly go through for GPs. I think is very important. You may have various types of ulcers. You may have traumatic ulcer, various ulcers, but most important thing what we want to know is how to, again I said, how to actually diagnose and see how to make sense of it. Next slide. For which I have a very simple formula. You look at a wound and I can rest assure you that any wound will only fall into this sort of a 5 different colors. So I call it a color classification. Okay, so let me give you some examples. So pink, red, yellow, brown, green, and black. So if you see a wound, just see what color it is. Next slide. So here's an acute wound, no question about it. So this is a red acute wound. We know how to treat it. Next slide. You find a wound like this. It's a pink wound. So when you see a wound like this, you just say this is a pink wound. I'll tell you why it's important. Next slide. Next slide. Now this wound, you say, what will you say? This is a multicolored wound. It's got black, it's got green, it's got all sorts of colors. I call it as a multicolor. This is an infected wound. Next slide. Okay, as you can see, there's a lot of discharge. Now this is wound. The color is a black wound. So you can have pink, multicolor, red. Next slide. You have a red wound. Next slide. And this is a multi types wound. You have yellow, you have green, you have yellow. So this is a combination of sloughy. If you have yellow wound, it's sloughy wound. If you have red wound, it's granulating wound. If you have pink wound, it's a healing wound. If you have multicolon, it's infective. So that's all. So first look at it, then your treatment management will follow. Next slide. So all you have to do is find out what's the color. If the patient has got multicolor wound, that's an infected wound. What we have to do is we have to do wound management to make sure that the infected wound becomes sloughy wound or necrotic wound. The sloughy wound should become a granulating wound. The granulating wound should become an epithelializing wound. And finally, the epithelializing wound should become a healed wound. So this is the normal sequence. Next slide. Next. So the treatment of wound management basically means three things. One is you have to find out what's the type of wound. That I've given you very simply. Just look at the wound, find out what color it is, then you know what type of wound it is. Then three things are important. One is how much is the wound area, how much is the exudation, whether it requires desloughing. So these are the next step. So moment you see a wound, if you find there's a yellow wound, two things you'll have to find out: whether the slough needs surgical treatment, whether the slough can be managed medically so that the wound can become better. So that's the only two things you have to see. The process of finding out what dressing materials we have to use, that's another topic which I'm not going to go into. But for today, all you have to know is what is the type of wound. Look at the color, make a decision, then you decide what sort of wound management you have to do. Next slide. So this is the simple things about what you put on the wound is a dressing. What you put on the wound for absorbing the X-ray is called the absorbing layer. Third layer is a retaining layer. So the dressing should have only three layers. It should be something to put on the wound, something to absorb the exudation, something to retain. So for example, you can have a bacteria dressing. I'll go very quickly. This is a very simple wound. Next slide. This is an epithelializing, very important not to make this a bad wound. So you should put a very, very, very soft dressing on this. Next slide. This is a very dirty wound. So this dirty wound will have a lot of exudation. So this wound will have a lot of exudative pads and then the dressing on top of it. Next slide. This is a black wound. Okay, this is an ischemic wound. Most of the time you don't need dressing. If you want to put a dressing, just put an ointment on the surrounding edges because this is not going to be exudative wounds. Next slide. This is a granulating wound. Ideally, this should require a skin grafting or something because waiting to heal, but is not healing. Next slide. Sloughy wound requires debridement. Here you have decided whether you'll continue with the medical treatment or surgical treatment. Next slide. So the whole idea of, keep pressing. The whole idea is that you have to make sure that the wound is going from the right direction from infection to healing wound or from sloughy wound to an infected wound. So this is what you have to do every day to assess what the wound is doing after dressings. Next slide. Oh, I'm not going to the details. This is the process of dressing. Now next, next slide please. So next what we had to do is once we have dealt with the wound, and you know now that remember what I told you before, you have pre-ulcer, ulcer you are treated, now you have post-ulcer. Post-ulcer patient has got the same or more risk of developing an ulcer again. So you have to see how to prevent these things. So the preventive strategies can be, most important is footwear, which is what is called the preventive footwear. You can also have the right type of therapeutic footwear. And I don't have to stress the importance of glycemic control. Next slide. Now coming to screening. So we came back, we actually treated this patient. Now we come to the pre-ulcer stage and the post-ulcer stage. You need to know whether these patients are going to get better or worse. You have to know who is going to get worse. So here is the most important thing of finding out the foot at risk. Next slide. So here we have to find out the patient got good sensation. What is this blood supply? What is the pressure is exerting on the foot on standing? Next slide. So do a examination, check the neuropathy on these patients. Next slide. Check for peripheral pulsation. You can use a handheld Doppler or get a color Doppler. Next slide. Depending on this, you have to tell these patients foot examination, footwear guide, diet and nutrition, and if possible, you have to have community programs where the patients can come and discuss it among themselves. Next slide. Risk stratification is if the patient has got increased pressure in these areas, but sensation is normal, he's okay. The patient has got increased pressure, loss of protective sensation, but no deformity, he comes into category 2. Next slide. Next slide. Footwear, we have developed footwear along with IIT Madras. Next slide. So I give a proper footwear where, just the previous slide once. Yeah, we give a footwear depending on where the ulcer is. We give a small wedge which will offload. Most of the time it's very useful. It's very simple footwear. And for a 4-foot ulcer, we give a midfoot wedge. For a midfoot ulcer, we give, as you can see here, we give a hindfoot wedge. And most of these ulcers will actually heal with proper footwear. Next slide. So what is that we need to know about the future research advances and in improving the patient outcomes? So I think as a collaborative GPs and the specialists, we'll have to see how we can actually improve the 3 things I told you. If the patient has got an ulcer and he comes back to you again with a high risk, how do we make sure that this patient don't re-ulcer again? We have to look at newer developments and hopefully develop collaborative partnerships. Next slide. I just gave you an example. Just want to tell you about how a plastic surgeon thinks. I think it's important that GP should know what a plastic surgeon thinks from his mind. We have the same principle as we deal with any other holes or problems in the body. As you can see here, there are always defects and loss of tissue. Next slide. And how we reconstruct them. The same principles happens here. So we could use the most modern PRPs or gene therapy or anything like that, but also to make sure that the surgical principles are taken care of. Next slide. So give you some examples. So here's a patient who has got a large ulcer. You can treat him 2 ways. You can give him proper, as you can see here, if you properly offload, this actually will completely heal. But you have to make sure that he's kept. So he's there from an ulcer stage, he's gone to post-ulcer stage, he come to pre-ulcer stage. The next important thing, either for you as a GP or me as a surgeon, is to make sure it doesn't re-ulcer. So that's the goal. Next slide. So here, these are the problems. We have to not just look at healing the wound, but we'll have to look at the maintaining the balance between the functions between the different organs of the body. Next slide. So the play between these 3 things, neuropathy, ischemia, deformity, infection, that has to be controlled. Next slide. So here, as you can see, most of these things will heal, but I'll show you some examples how we treat them with flaps. Next slide. So here, this patient had an ulcer in the midfoot. As you can see here, this patient had a collapse on the midfoot, but ulcer in the forefoot. So the treatment has to be to the midfoot. The forefoot is a symptom, whereas the cause is the foot. The patient has got a midfoot collapse. Ulcer is in the forefoot. So that you have to be very careful. Next slide. This I showed you. This patient has got multiple times he's got ulcers. So we treated him with a flap. This patient has got a bony deformity, repeated infection, so we treated him. This patient has got a charcot foot, not healing, so that has to be treated surgically. Next slide. Next slide, please. Yeah. Now, having treated, the patient has to be under surveillance. Patients who got neuropathy, if they develop an ulcer, the muscles are also poor. So the chances of being treated surgically with a muscle flap also becomes very poor. So neuropathy, don't think it's only loss of sensation, it's also muscle atrophy, where as plastic surgeons, we find it very difficult to find muscles to treat these patients. Next slide. Vasculopathy, as you all know, we can't do flaps if the vascularity is there. Next slide. Okay, now this is very important. This is very, previous slide, please. Previous slide, previous. Yeah, so this slide is very important. Okay, this slide, this is the first slide which as an undergraduate or as an early postgraduate or as an early surgeon, we were told that if the patient has got vasculopathy, no role for flaps. What do the modern vascular surgeons tell you? Next slide. Yeah, so the present what it says, if the vascularity is poor, improve the vascularity. And that can be done very effectively by well-trained plastic surgeons, either through angioplasty or whatever. So this is what you have to understand. The patient has got vasculopathy. Please make sure the vascularity is got better. Then a plastic surgeon can operate. So don't just say the patient got vasculopathy, no further treatment. This thing can be assessed. So this can be assessed with the help of what's called a transcutaneous oxygen measurement. After bypass or after angioplasty, we can still go ahead and do our major flaps, provided they are done properly. Next slide. So that's a present thinking. If the patient has got multiple wounds and we can't operate, we have to make sure they are given a proper footwear. Next slide. Even after wearing footwear, if the patient has got failed secondary healing, please consider treatment with surgical treatment. Now, this is failed secondary healing. So, patient has been wearing footwear, not possible to treat, failed secondary healing, complex defect. Please think about doing a surgical procedure. Next slide. So, this we published again, our own patients. In 2009, we published of how to select patients when they failed. Next slide. So, this patient, as I said, is a complex defect, failed secondary treatment. We do flaps, treat it properly. Finally, we give them footwear. So it's very important that if the patient has got a problem, assess them, see whether they are chronic problems, correct the problems, bony defects. If they still don't heal, think about surgical treatment for these patients. Next slide. Next slide. Now, the most important thing is common to you and me is compliance. Most patients are not. How do you know whether the patient is compliant or not? First, nobody talks about it. First thing is, please look at the general upkeep of the patient. The patient will not be very clean, not looking after himself, not eating food properly. That's the first indication that the patient is not going to be compliant. So if you're going to do major procedures, we have to know whether the patient is going to adhere to whatever we say. So those patients, we look at these things. If the patient has got good mental makeup to take care of his feet, he's a good candidate. So surgical things can fail if the patient is not a good candidate for surgery. Next slide. And lastly, we may have to do what's called biomechanical abnormalities, tendon lengthening and tendon changes. As you can see here, the patient has got a non-healing ulcer in the forefoot. The tendo Achilles can be tight. You release the tendo Achilles, then the foot will heal properly. This, of course, I can't stress the importance of debridement. Whether the debridement is a major debridement like this or a minor debridement, debridement is a very important step. So that's why when I told you, whenever you see a patient and he's got a yellow wound or a green wound, the first thing you have to think about is to make sure that all the dead tissue and bacteria is removed. So debriding is two things. One is debriding means removing all dead tissue. Debride means it's removing all bacteria, removing all foreign body, removing biofilm, and at the same time making sure that you protect the normal tissue, you be gentle, and you can use more modern modalities to make sure these things are achieved. Next slide. And reconstruction, I don't have to go into the details. A good reconstruction will be a good saver. So these are the 10 checklists we go through before we do a flap in the patients. I'm not going to the details. Again, don't forget the patient has to have a time duration. If the patient is not healing in 4 weeks, 6 weeks, or 8 weeks, then please rethink about it. Next slide. So principles of this thing. Quickly, let me go through that. The principles of surgery, plastic surgery, assess the wound. Now, this is the checklist which I go through. So assess the defect, plan, and execute. This is the principle of plastic surgery. Very quickly, I'll go through how I see in the patient. I told you very simply, look at an ulcer. Look at an ulcer. When the patient comes to me, I just look at the ulcer and say what color it is. If it is
Hello.
hello, sir.
Yes, sir. Yes,
Hello?
sir.
Okay.
Now
So-
we are able to hear.
Yes, sir. So next slide. So this is what I want to just highlight. When a patient comes to me, first thing I look at it is I look at the color. If the patient has got, let's say, pink, I'm very happy, making sure that I have to maintain this properly. If it is black, if it is green, if it is red, then the algorithm of what I have to do goes on. So the first thing, this is my case sheet I have in my clinic. If the patient's ulcer, I look at it. Next slide. If the patient has got ulcer and wound, then it becomes deeper. Okay, very simple. Next slide. Okay, so if the patient has got next, I look at neuropathy, vasculopathy, osteopathy, next is infection, system. So each one of them I actually evaluate in the OP itself. You'll have to find out all these things are happening. Don't just look at the feet and then say, because everything can be done, as I told you, all these things can be evaluated in the OP itself very quickly. And then next slide. Next slide. And then very important, if the patient has got a massive wound, then I decide whether he needs a massive surgery. Next slide. Next slide. So this patient has had a very small wound, but she's got liver failure, she's got hyperbilirubinemia, she's got hypoalbuminemia. So this patient, I know, is a very, very sick patient, and I had to decide what sort of treatment I had to give. Okay, so I don't just look at the wound itself, I look at the entire thing and calculate. So the classification I told you about, one is look at the color classification, second is the time classification. This all happens in your head, but you can I can tell you that this can be recorded also. So first thing is look at color classification, second is time classification. Find out how long it has been, whether it's an acute infection. Next slide. Then you know it's subacute infection. Next slide. Which should heal. Then you know whether it's a chronic infection or acute and a chronic infection. Next slide. This is an acute and a chronic infection. Patients are coming to you with a small wound, suddenly they become very big. So this is chronic, non-healing, non-infected. No need to treat this with antibiotics. Next slide. Then I told you, potentially infected. So having collected all this data, what do I do? Okay, next slide. What I have done is very simply, I have put them, I told you here, color, time classification, color classification, time classification, status of foot, status of diabetes, status of organ systems. Next slide. Based on that, I developed a very simple scoring system. Next slide. And then if the patient has got acute, that gives me an urgent, this thing to make sure that I treat this patient urgently. So red means the patient has treated very immediately. Next slide. Next slide. Yeah. Then if it is green, the green and yellow will be in the GP's lens. Say, for example, if the patient has got a newly diagnosed diabetes, no ulcer, early neuropathy, he'll come in grade 0. So that is for, next slide, please. Yeah, let's say, for example, this patient got multiple ulcers, he's got neuropathy, poorly controlled diabetes, system not controlled. So this gives me an indication. I had to actually diagnose a patient when I see a patient when he comes to my clinic. So how do I diagnose this patient? So this patient, I'll say, this patient has got bilateral, multiple site callosity with arch collapse, diabetes poorly controlled with no organ system development. So this will be my diagnosis. Next slide. Next slide, please. So depending on that, initial patients, I told you small ulcers, I treat them with footwear. I make sure they come to me within about 2 months or 3 months or 2 weeks. I see them and find out whether the patient is healing. If the patient is not healing, then he becomes a candidate for further evaluation. Next slide. So this is again a patient who's got an ulcer, grade 2A, which means that the patient has got uncontrolled diabetes, has got ischemia, has got neuropathy, has got an ulcer, but is not acute. So in those situations, give them secondary footwear, see the patient how they are doing. If the patient is feeling ill, then they will continue to have diabetic management and conservative treatment. Next slide. If the patient comes with an ulcer, then I get treated. Okay, so this is again the most difficult patient. Small ulcer, but systemically very difficult. So these patients get treated. Next slide. Surgically. So when you have a patient who's got a score about 10 and a grade 0, then he needs awareness program. So my patients who come to me, newly diagnosed, no ulcer, no neuropathy, no vasculopathy, then we give them lectures on how to take care of them. The patient has got, as I told you, risk stratification 2. So those patients will come for preventive. Then you have procedures for emergency treatment and urgent treatment. So to conclude, I think what we have to say, GP's domain is very important. Imaging, empirical control and management. Be aware of the incision planning. You should also know the domain about research, choosing the right footwear. Be aware of the diabetic foot reconstruction, and wound management or wound dressings. Next slide. Thank you.
Thank you so much, sir. And Madan, are you?
Thank you, sir.
Yes, please.
Thank you.
Please take over.
Thank you, sir. It
Thank
was an
you.
exhaustive and a detailed lecture about diabetic food. We are all were enlightened by your talk, sir. Thank you so much, sir. Shows
Sorry, I
your
couldn't share the
experience.
video. Sorry, I couldn't share the video. I don't know what happened.
Oh, thank you, sir.
Okay, sir. Video will be shown in the CGP course, sir.
Okay,
Yes,
thank you.
Yes, sir. Sir, now we'll have the QA session just after our introduction of about fellowship course, sir, by our Rai Kumar, sir. So now I
Sure.
request Dr. Tirumurthy, sir, to introduce our next speaker, Dr. A.K. Ravikumar, sir, immediate past secretary and chairman, Hospital Board of India. Yes.
In the meantime, I request everyone to have the questions in the chat box.
Hello, sir. Audible?
Audible, sir. Proceed, sir.
Okay. Welcome, our Dr. A.K. Ravikumar, sir. I am introducing Dr. A.K. Ravikumar, MS General Surgeon, Chairman of IMA Hospitals Board of India. He is a general laparoscopic and diabetic foot head surgeon. Director, Mouthi Nursing Home Private Limited, 40-bedded multi-specialty hospital in Coimbatore. Worked as Honorary Secretary of IMA Tamil Nadu during COVID period 2021. Was Chairman of Hospital Costing Committee. He is a certified and qualified implementer for hospitals. Was a member of the Clinical Establishment Act Formulation Committee of Tamil Nadu. Tamil Nadu Medical Council Best Doctor Awardee 2021. During his various capacities in Tamil Nadu in IMA, he was awarded Best Office Bearer Award many times, both at state and national levels. Receiver of Rotamet Award 2010, Doctor of Excellence Award for Healthcare Services. Research papers on diabetic foot was awarded Best Paper Award twice at national level and also at the state level. Presently, he is the Chairman, IMA Hospital Board of India 23-24, member IRDA Health Insurance Forum, project coordinator for Rotary Global Grant Project on Save Limbs in Diabetics, course coordinator for Diabetic Food Fellowship Certificate course in IMA Tamil Nadu. Thank you, sir.
Thank you so much for introducing such a nice words from you. I'll just go ahead with the sharing of the slides. I thank the office bearers of Indian Medical Association, Tamil Nadu, and the CGP wing for giving this opportunity to work on and give a course on the diabetic foot problems. And I thank Dr. Narayana Murthy for coming over and giving an elaborate discussion on the basics and how to practice and when to refer and when to handle by themselves and when early to intervene and what are the conditions which need flaps. So entire scenario has been taken care of by our Dr. Narayana Murthy sir, who is the
Thank you.
who is actually the president of the Diabetic Food Society of India. And my job is now why you have to join a diabetic food course. So you would have seen all the presentations of Dr. Narayana Murthy. That itself shows that diabetic foot is a big area. It's a specialty by itself, and you need to know more when you want to save the limbs of a patient. One of the most devastating complications which leads to suffering, disability, loss of working hours, prolonged hospitalization, above all the expenses, and ultimately may end up in amputation if not properly being treated. And it is the duty of the family physicians to take care of the feet of the patients who come to you. India is the diabetic capital of the world, and overall prevalence is from around 15 to 20% of the diabetic foot problems, and 70 to 80% of the foot problems occur in the neuropathic foot, that is an insensate foot. And amputation rate varies from 2.5 to nearly 25 to 30% in various countries and also in various scenarios. 80% of the diabetic foot-related amputations are preceded by ulcers, which you would have seen by the presentation from Dr. Narayanamurthy, sir. Somewhere in the world, a leg is lost every 30 seconds due to diabetes. Most of these are preventable, and amputation rate can be decreased by about 50 to 85%, provided early identification. See, these are the lines which I just wanted to underline. This early identification is an important one. Proper early intervention. So here again, the intervention must be early, and there must be a proper foot care, and a proper follow is also mandatory. If these are being done, where the family physicians and the diabetologist's role is very, very important. So our diabetic foot care course, why it is important is, our undergraduate and postgraduate curriculum doesn't have structured program on diabetic foot management. Majority of the foot problems are either missed or mismanaged. So majority are referred late to be saved. So why? This in our course, the diabetic CGP course, it gives an insight on the basic anatomy. It gives an insight about the pathophysiology of the diabetic foot and how to do a foot examination and how to do foot screening and the biomechanics of the foot, which leads to the various deformities of the foot if not being properly assessed, and the gait cycle, how it helps to understand the gait of the patient and to understand why the deformities develop in the patient's feet, and the various investigations, plethora of investigations, which are available to identify early the problems of the diabetic foot and their interpretations, and the classifications, the various classifications, and the simplest classification which one can follow in their practice. We give an insight about the preventive and therapeutic interventions available and what are all the follow-up protocols which we should follow and how you can set up a diabetic foot clinic. These are the insights which we are going to give you. And we have online classes, we have workshops, and we give also the hands-on training about how to handle the diabetic foot patients. So the surgical anatomy we will be dealing about. We'll be dealing about the various plantar spaces and how an infection in a toe can ascend to the sole and then to the leg. So Dr. Narayanamurthy detailed about that and the various pathophysiological triad, that is the neuropathy, angiopathy, and the infection, and the various biomechanics of the feet. We deal about the various movements that happens in the feet. We'll deal about, and we will give you an insight about how important the foot movement, the joint movements in the feet, and if they become rigid because of the neuropathy, what will happen to the feet and how to identify them very early. And we will teach you about the normal gait cycle and how to assess the gait of a patient when he is walking into your clinic, when he comes to the clinic. By just seeing how he walks, you can assess the patient's feet and you can treat him accordingly. The various phases of the gait, and you have the various investigations, modalities. The very simplest one to find out the neuropathy, which is the monofilament one, and the use of the biophysiometry we will teach about you, and we will detail about the biophysiometry's implications and how foot Doppler will help and how to interpret the results of the biophysiometry and the various screening equipments which can be used to find out the various foot problems like the tip term, which will, and a small vibro tip, which can help you to assess the neuropathy. And this I would say the vascular Doppler. This is the like a stethoscope for a doctor. A doctor who handles the diabetic foot, he should know how to handle this Doppler, hand Doppler, which is a very, very handy instrument with which you can assess the vascularity of the foot, and the Harris mat to take the impressions, and the advanced one, the Podio scan, how to do the scan and how to interpret the results of the Podio scan. We teach you, and we will guide you about assessing the various types of the feet, the various, you can see the various deformities and the various thickening of the nails and wasting of the muscles, how to assess that, and we will guide you about how a deformed foot will develop callosities, and if how the callosity is going to get ulcerated, and how an ulcer can get infected, and if the patient comes to you at various stages, how to handle those patients. You can see here the various types of feet which will come to you in your clinical practice, and when you should not ignore and when you should handle it, these problems. Here you can see the mallet toe, you can see the wasting of the muscles, clawing of the toes. So you have to identify them early in your clinic and treat it properly. You just cannot leave this as like this, and this is going to get ulcerated, and once it gets ulcerated, then it will end up in amputation. You can see the various nail types, how it is there, and we will teach you how to trim these nails and what all the gadgets you have to use in trimming these nails and the callosities. We will teach you, and we will guide you how to assess the feet for a footwear, how to customize the footwear according to the feet of the patients. These are all the various deformities by which the patient can approach to you, and the proper footwear by itself will go a big way in preventing ulceration in these patients. You can see here, see this is a small wound left unattended by the general physician. You can see that it is a callosity, but underlying the callosity, you have a big cavity with abscess. And here you could see that at the toes, the two toes are gangrenous, and it can ascend up. We will also teach you about how to take swab, how to assess the depth of the wound, and when you can intervene, and how you can do the decompression, and how to do debridement. All these things we will teach you. Here you can see how a proper amputation and the decompression has been done and how the wound has healed. You can see how to decompress it and how the wound has healed. And here again, you can assess, we will teach you how to assess a sinus, assess a wound if the patient comes to you with practical patients. Here you see a small blood fissure which got infected, which was, had this immediate intervention has not been done, this would have gone for an ascending infection and the patient would have landed up in a very big issue. But now immediate intervention and de-roofing and debridement will save these feet. Here again, you can see a sinus with abscess and how to handle that. We will teach you. And you cannot ignore the fissures of the feet. A fissure, it can have an underlying abscess. You can see here, the first slide, it looks as if it is a healed fissure. It's not like that. When you just de-roof it, you can see an underlying ulcer there, and that can lead on to infection. So you have to do it as early as possible. You can see how to debride it, and early identification of the foot problems and debriding it will give a very good salvage to the patient's feet. Here, this toe has been ignored that the wound has healed, but it is not so. When you just remove that scab, you can see an ulcer underneath. So you should know how to handle it. Here again, you could see that as if the wound has healed well. It's not like that. You have to debride it, and once you debride, you can see a big ulcer underneath that. If you're not going to take care of this at the early stage, the patient will have osteomyelitis, ascending infection, and he may lose the feet if not properly handled. Here you see people, the treating physician has thought that the wound is healing. It is not so. If you debride it, you can see a big ulcer underneath. So proper debridement has to be done, and early identification has to be done. So it is not only the dressing, mere dressing and debridement. You should know when to offload, how to offload, and the various offloading techniques which are being used to offload the ulcer. Offload means you relieve the pressure from the ulcer. Unless the pressure is relieved from the ulcer, ulcer is not going to heal. So these are the various easy techniques of offloading which you can practice in your day-to-day practice. We'll teach you how to do these offloadings with glove bags, with walking heel. Actually, I am proud to say that this walking heel paper, which I presented in the Indo-US workshop, got the best paper award. This is one thing, and we will teach you how to do the midfoot offloading. Midfoot offloading can be done with sponges. So those techniques, we will guide you, we will teach you. So how to have a walking heel, because total contact cast is the gold standard for any forefoot ulcers or the plantar ulcers. But our people, our economical situation cannot warrant for that. So we have to take care of the economy of the patients and see that the patient can go for his day-to-day activities. At the same time, he has to take care of the ulcer. So this is the walking heel which we designed, and patient's forefoot ulcer has been treated with the walking heel where he can drive his cycle, he can drive his two-wheeler, he can go for his work and come back for the dressing, and the wound will get healed. So healing alone is not the solution. We should see that it doesn't get re-ulcerated. So the various offloading footwears, the various customization of the footwears, we will teach you about how to customize the footwear, what are the types of footwears available, how to assess the pedo scan and order for a footwear. So all those things we will teach in the course. So these are all the various customized footwears for the feet ulcers. So the midfoot ulcer healed with offloading, and we have customized the footwear for him. And the most important one is the patient has to wear the footwear both indoor and outdoor. So here you can see this sort of feet which was totally mismanaged, and the patient landed up in this situation where multiple sinuses, gangrene, and ascending infection, and he was referred for amputation. But various debridements and various interventions, we could save the feet, and we customized the footwear for him, and the patient is walking with the footwear now. So these are all the various types of footwears, how we can customize for the feet. We will teach you, we will guide you how to do that. And finally, we will guide you how to set up a theater, podiatric theater. So we will what are the, this is the podiatric chair. You have the various kits which you have, which you can use to handle the various types of corns, callosities, thickened nails, and all those things. And the drill, which you can use for shaving the corns and all, how to use these electric drills. All those things we will teach you. And there it doesn't stop. We have to create awareness on the various preventive measures to the patients. We'll give a guidebook to you about how you can teach the patients, and you give the booklets, the preventive measures and the foot care booklets to the patients. We will guide you and give. This is the first set of doctors who underwent the workshop in IMA CGP, and I am proud to say that 6 of these doctors got the medals in the diabetic foot course. And this is our paramedical staff who helped us. And we have Dr. Thangavelu here, the physician. So it is not, as I said, it is a teamwork. We have a vascular surgeon, we have the plastic surgeon, we have pathologist, we have general physician, vascular surgeon, all taking various classes for you and get the benefit. These are the clippings of various workshops which we conducted in our course. So we'll be doing the cases in the theater, and all the people can watch how it is being done. And we'll give hands-on also. You can see Dr. Bharati Selvan is handling the patient and seeing there. Dr. Leo is there. And I am glad to say that the Rotary Global Grant Project on Save Limbs is being done in our hospital, and I am the coordinator for that. And I am proud to say that in the last 3 years, we screened nearly 3,599 patients, of which we could identify the foot problems in 1,722 patients. And the amputation rate is only 2. Out of 1,722 patients who we got hold of, we treated them, we got them in various stages of the diabetic foot, and we could save almost 1,720 patients, and only 2 patients had to go in for amputation because of total, sepsis, and we could not save the limb. So, which is far, far less than the international statistics of 2 to 25%. Ours is only 0.11%, which is, this shows that we need education, we need involvement, we need to identify them early, pick up them early, intervene aggressively, and handle them properly, and refer them when and whenever it is necessity. Though amputees can be winners, not everyone can be so. So thank you so much. Thank you very much. I want more people to join this course and save the limbs of the patients. Thank you very much. Thank you.
Yes.
Thank you, sir. Thank you, sir. You have explained the diabetic management very crisp and clear. All the practitioners in and around it will.
Hello. The signal is not proper, I think.
Sir.
Yes, Sandeep.
Sir, thank you, sir.
Thank you, Sandil. I think we can take a few questions. Is it not, Madan, Sindil?
Yes, sir. Yes, sir. We can take.
Dr. Narayana Murthy, sir. Sir is very busy. Dr. Narayana Murthy, you know, he is a very, very busy plastic surgeon. And I know him for the last nearly about 15, 20 years, where the initial stage of Diabetic Foot Society was formed. We were all, we joined as the founder members. And Sir was at that time doing research in the Leather Institute. And he used to always tell that we have to do research in the diabetic food, and it must be to the poor patients of our land. So that has given a fruit for him. He has patented so many footwears and the methodologies. So hats off you to sir for having accepted our invitation and have come and elaborated us here. So you can get some clarification with him if any of the questions are there.
Sir, Madan sir, kindly coordinate, sir. We can have some QA session.
Yes, sir. I'll coordinate, sir. There are a few questions in the chat box, sir, for Narayan Murthy, sir. One minute, sir. Sir, what is the timing of angioplastic procedures post wound debridement in a vascular diseased limb? Sir, Narayan Murthy, sir. Can you hear me, sir?
Mute, I think.
Muted.
You have to unmute. Someone.
Yeah.
Dr. Sindhil, if we are a host, you can unmute him.
Sir, he is unmuted, sir.
Yes, sir. Please, sir. Narayan Murthy, sir.
Sir, can I repeat the question, sir?
Sir, question for you, sir. Narayan Murthy, sir.
What is the timing of angioplastic procedures post wound debridement in a vascular diseased limb?
So he is showing something. Sir is showing something. They're able. Hello. Some issue.
Sir, he is.
Hello,
sir.
Sir, it says the host is not allowing participants to unmute themselves.
Oh, sir is unable to unmute.
Sir, it is
you can
already.
Just, yeah. You please unmute him. Unmute him, please. Comes as. Can the host unmute him? Yeah. Now you are unmuted, sir.
No, it still says host is not allowing participants to unmute
sir,
them.
Yeah, it is in the screen. It shows that you are unmuted.
Sir, we are audible, sir.
Can you hear?
We are able to hear you, sir.
Yes,
sir.
Yes, sir. Yes.
Okay. Actually, I have actually replied to them. The ideal time. Ideal time to actually do a vascular intervention before debridement is to check if the patient has got ischemic problem. So the timing will be if the patient comes to you with a infection or something, and you find that this patient has got ischemic limb, better to do an ischemic intervention, then you can do a proper debridement. If the patient is very sick and there's a lot of slough, you can do a very conservative debridement and then do a vascular correction.
Okay, sir. Thank you, sir. What is the outcome of diabetic foot care better in male or females?
I don't think there is anything. Generally, there are more males compared to females. The incidence of vasculopathy between male and female is not very different. Only thing is we find more males affected.
Okay. What's the role of ultrasound in diabetic? I think you already mentioned the role is not very.
Ultrasound predominantly is for your vascular assessment, color Doppler. And we also use it for nerve blocks. And then we can use it for finding out if there's any collected blood abscess or something like that.
Okay. What is the role of topical creams in wound management?
Yeah, I think it's very important. You remember what I told you about the different types of wounds. So if you say the patient has got an epithelializing wound, make sure that you don't put anything on that. You have to give a very thin, non-adherent material which will not damage the thin epithelium. Then you have the red granulating wound. Red granulating wounding predominantly is a sterile wound. There is no need to put anything. Then you have the grossly infected wound, where you don't have to put anything. You may have a newly debrided diabetic foot wound with infection, where you can put topical antibiotic. The other thing is for prevention. If patient has got a shoe bite, small injuries, scratches, then you can use antibiotic cream. The other thing is I told you about the dead wound, which is a black wound. If you have black wound, that particular tissue is dead. But the junction between the dead wound and the normal tissue, that's very friable. So you can use antibiotic cream in that junction. Then of course the last wound I told you is a sloughy wound. Sloughy wound predominantly needs surgical debridement. So always think about which wound you are dealing with. There are only 5 different types of wounds with a combination.
Okay, thank you, sir. Is there a role of nerve transfer in tackling the sensory neuropathy in diabetic?
Yeah, we don't do nerve transfer, but we do nerve decompression. So I didn't talk about it today. If patients have got neuropathy, pain with neuropathy, difficulty to sleep because of pain, severe clawing, then we do nerve decompression at the tarsal tunnel. That can help.
One minute, sir. Does burning feet lead to diabetic foot?
Burning feet?
Lead to diabetic foot.
Yeah, see, the burning feet is because of the nerve getting irritated and inflamed. It is not the burning feet which will cause the ulcer, but if the burning feet has got neuropathy, he's got loss of sensation, then he get an infection, injury, then he can get infected. So the feet are prone for infection because of injury.
Hydrogel or colloidal ointment, when to use it, sir?
Hydroheal, they are very good ointments, but 2 things. One, it will keep the wound moist. Second, it will actually have some amount of absorptive capacity. So again, think of the 5 different types of wounds I told you about. Epithelial wound, thing. You can use it in granulating wounds because it will actually keep the wound very healthy, moist, and any small exudate it will exudate. Infected wounds, it's got very little activity, but you can use them after you have debrided it. Frankly, infected wounds, I think they had to be treated with debridement, and then you can use hydroheal there just to keep the areas moist. And they can also be used in granulating wounds. Sloughy wounds, of course, you need to debride them. So it's a very useful gel for use.
Okay. Thank you, sir. Patient complaints for TCC in our setups.
Yeah, I think if you put TCC, very little chance that they'll take it off. But if you put them just a half POP or half, then they will take it out, definitely. Even if TCC, there are people who will take it off.
So what's the footwear for a minor plantar ulcer patient while driving car?
Yeah, I think it's very important that people who are driving cars have a neuropathy assessment. So far, I have not had anybody who's had an accident because of neuropathy. But I've had a lot of people coming with ulcers. They have been on long journeys. Especially, I had people, same day they went up to Kanyakumari and came back. They had burns in the forefoot. So there, the footwear is not going to help much. They had to make sure that they break the journey, give the foot some rest, inspect the foot, and then take care.
Sir Tirumurthy sir, actually, sir has few questions to ask.
Yeah,
Sir.
Tirumurthy sir, you can ask your question, sir.
Okay.
Yeah.
Sir, how to identify here, sir?
Yeah, I can hear.
Audible?
You can. Yes, sir. Yes, sir. You are audible, sir. Please go ahead, sir.
How to identify or differentiate which diabetic wound go for debridement or simple wound dressing?
Okay. See, again, you look at, I told you the different types of wounds. If the wound looks predominantly pink, that does not require debridement. If the wound predominantly looks red, that means it is waiting for a graft or a skin to come. Then you have two different types of wounds. One is a granulating wound, then you have the infected wound, and then you have the ischemic wound.
Okay, sir.
If you have the ischemic wound which is black, in old people, I will leave it actually. Just do a dressing, put a antibiotic cream around the edge. It will become okay. You may have to debride it.
Okay, sir.
If you debride any wound, you are allowing that wound to be treated either surgically or it has to heal. So a sloughy wound, which is the yellow wound I told you, that requires surgical treatment. If they're very small, you can try debriding agents and other things. So always remember the 5 color wounds.
Okay, sir.
Pink, nothing to do. Yellow needs debridement. Red is granulating wound, no debridement. Green and black may require debridement. So only 5 different, there are no different wounds. 5 colors you remember.
Okay, sir. Another question, sir.
Yeah.
Salient points, indication for weak amputation and diabetic foot turn.
Yeah. One of the most important thing is if the patient does not have adequate vascularity. That is very clear. Second thing is if the patient has got infection going beyond the ankle and is getting systemically worse and you're not able to control. Third is if the patient has got all the tissues lost and you don't have a proper reconstruction. Supposing he is lost up to the above the ankle, then there's nothing to reconstruct. So that is where your Wagner's classification will come. How much of tissue is lost? Whether the toes are lost, midfoot is lost, above the ankle. Then you can decide whether below knee or reconservation.
Okay, sir. One more question, sir.
Yeah.
How to select the antibiotics in diabetic wound initially before pus culture and sensitivity?
Yeah. So it's very important that you start them on antibiotic before culture.
Okay.
Now, if the patient has got, let's say, a small toe infection where the tendons are not involved, a superficial infection. And the patient does not have much of systemic, like say he doesn't have hyperglycemia, no leukocytosis, no fever. These patients, you can give them first generation cephalosporin. I put them on cefalexin.
Okay, sir.
Supposing they start developing slightly more infection, and the timing is also important. Generally, in the first week, the infection is due to gram-positive cocci. Those patients, they start them on clindamycin or augmentin. Subsequently, if the infection becomes slightly more, if the discharge is large and the area is bigger, and there's a lot more tissue death and slough, then I go for either piperacillin or cefepozan. Very rarely I have to use meropenem regularly in the outpatients, but it's become very sick and go to the hospital, get ICU, then obviously they get a higher.
Sir,
Thank you, sir.
any other questions, sir? Okay, sir. There are a few more questions, sir. We'll quickly try to finish up in the short span of time.
Yeah.
Does capsicum ointment relieve burning feet?
Capsicum actually, it just causes some cooling. After you put the capsicum, it actually causes cooling. But it doesn't last for too long. But it's initially for a short period of time, it's okay.
Is there a role of methylene blue or other dyes such as ICG in accurate demarcation in wound debridement, like in pseudotumor excision in pressure sore or in early excision in burns?
No, here usually by visual inspection, make sure that the bleeding well. It is not what you take out. It is what you leave.
Recurrent callosity in the same place.
Yeah. So recurrent callosity, you think about what I told you. Recurrent callosity is potential infection. There is a problem underneath. The bony correction has to be done, and then proper footwear. If necessary, you'll have to give them a flap procedure. So initial treatment is fine. The most important thing is what happens if it doesn't heal. If it requires repeated sort of a treatment, then they need surgical correct.
Is peripheral neuropathy reversible with large doses of vitamin B12?
See, vitamin B12 is not the only cause. If you can, in fact, vitamin D can be the cause of neuropathy. B12, usually you'll find that levels are normal in many people. The cause is actually the neuronal degeneration. Added to that, you have the compression. So if the patient has got compression also, we release the compression, some of the patients actually get better.
At what stage of diabetic foot can we use the collagen powder?
Yeah. See, collagen powder, when you have a granulating wound and the patient doesn't want any surgery, they're very happy to have these powders. So I would use them for non-infective, non-healing, small wounds in non-weight bearing area. That you can use. That they'll help.
When should we refer diabetic patients with foot ulcers? With burning sensation or numbness?
Actually, see, the ulcers is independent of numbness or burning. The ulcer is a symptom of progressive neuropathy and numbness. So it doesn't depend on whether severity of the numbness. When you have an ulcer and neuropathy, it has to be dealt with both. Sometimes I do nerve decompression for ulcer patients.
Okay. Previous history of diabetic foot ulcer and used antibiotics, recovered, but again comes with presenting complaints of necrotizing fasciitis with antibiotics resistance. Without amputation, what would be the treatment of choice?
See, necrotizing fasciitis, generally, there's no need to do amputation because they only are superficial infections. You need to do a thorough debridement, then you'll be able to save. Very rarely we have to do amputation for necrotizing fasciitis.
So a few questions are regarding the courses, sir. That way we can, our CGP members can explain to them later.
Sure.
Application of Band-Aid in simple superficial ulcers in diabetic type 2 cases, is it accepted, sir?
You rarely find a small wound to actually use a Band-Aid in the foot. Better to have a nicely aerated dressing rather than have this sort of a closed dressing action. But the most important thing is to wash the wound and then clean it. And then you can put a Band-Aid.
There are tens and hundreds of vitamins and add-on molecule combination prescribed in diabetic neuropathy. Which one is practically useful, sir?
It's difficult to say. I don't prescribe any of those things. So I think the physician should be answer that question.
Few words about use of epleresetat in foot ulcers.
See, scientifically, there's no explanation to say how they work. But if you can use them and work, I think there's nothing wrong. I don't use them.
What is the 5-year survival rate of class 3 or 4 diabetic foot patients?
Class 3 or 4, you mean Wagner's classification?
Diabetic foot patient, yes, sir. Class 3 or 4.
See, Wagner's classification is only a volume loss. Even with a below knee amputation, it is suggested that the 5-year survival is very less. But it actually depends on the cardiovascular status and other things. But yes, the higher the amputation rate, the mortality is higher.
That brings us to the end of the questions, sir. One more last question. What about VAC?
Yeah, VAC is very, very useful. You have to be very clear. Again, look at all the 5 wounds I told you. You cannot put a VAC on epithelial wounds because not necessary. You wouldn't be able to put a VAC on the what's called a black wound, which is a necrotic or ischemic wound. You will not put a VAC on infected wound, which is draining a lot of pus. So you're left with only 2 wounds. One is your sloughy wounds and granulating. So sloughy wounds is after you debrided the infected wound, infection is under control, there is some dead tissue. That dead tissue also you have to remove. After you remove all the dead tissue, there is no infection, then you can apply VAC because it will help granulation, it will control the exudation, and actually 2 things it will do. It will try to help to get more antibiotics, nutrition, keep the wound clean. That will help the wound heal well.
Use of hydrogen peroxide cleanings.
I use hydrogen peroxide to clean the blood around the ulcer, not on the wound. Actually, there is no need to put hydrogen peroxide in the wound.
Okay, so that brings us to the end of the QA session. Sandil sir, can we wind up? Okay, sir, I propose vote of thanks for this excellent CME program. I thank the state president, state secretary, the treasurer, and all the IMA office bearers for allowing us, the CGP team, to conduct an exhaustive talk on this diabetic food management. I thank the speakers of the day, Dr. Narayana Murthy sir and Dr. A.K. Ravikumar sir, for detailedly elaborating about the disease and the course which we are going to conduct in CGP. I thank all the members who've been actively participating in this program. It's almost 6:30 and we have 320 people still online. So that shows the interest people have. So thank you so much for an excellent session. Thank you all the participants for joining and making the CME program a huge success. Thank you so much.
Thank you very much. Thank
so
you.
much.
All the
On
best.
behalf of CGP team, sir. Thank you. Thank you.
Thank you, sir.
Thank you.
Thank you, Ravikumar.
Thank you, sir. Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you.
Yes, sir. Sir, Nalla, initially it was thought to be a dry topic, sir, but it was nice interaction, sir. Nalla poiruchu,
Yeah,
sir.
yeah. Quite nice.
Yes, sir.
Was
Yeah, we
nice,
also had
actually. Yeah.
almost 750 participants, registered participants today.
Yeah, yeah.
Oh, good.
Yes,
Very
sir.
good. I wonder why my I could not share my screen.
Share the presentation, sir. Yes, sir. Yes, sir. Maybe small hiccup should be there, sir.
I don't know why actually.
Okay, sir.
I'll find out.
Yes.
I'll find out.
Yes,
Sir, people want the PPT, sir. Few of us want the PPT.
Yes,
I
sir.
sent it actually. Sent it to.
Yeah, it's
There.
with me. It's with me. I'll share in our group.
Sure, sure.
Okay.
Thank you.
Can I share, sir, with your permission?
Yeah,
Dr.
yeah,
Narayan
please.
Murthy, sir?
Yeah, go ahead. No problem.
Okay, okay.
Sir,
See,
and also
I wanted one appeal actually. See,
Yes, sir.
there are various classifications. None of those classifications are good enough. I have my
Yes,
own
yes.
classification, which as part of DFSI, I'm planning to see if
Yes.
you can get at least 10 people around the country. I want you people to, if you are interested, I'll send you the protocol of how to do that. Very simple. 45 patients of different categories or even 100 is very easy. If you get 100 patients from, let's say 10, no, you'll have 1,000 patients actually. So I will send you the details. If you're interested, any one of you can join.
Yes, sir. Yes, sir. Please, sir, share.
I'll send it to you.
Share. Yeah.
Yeah.
We will circulate and we will get persons who
Yeah.
are doing food cases. We will make use of it, sir. Sure, sir.
Okay.
Sure.
Okay.
Sir, and
Thank
we
you,
also
sir.
want your presentation, sir. Ravikumar, sir, your presentation also we need, sir, to share.
Okay, okay. I'll send it. Send
Yes,
it
sir.
across.
Yes, sir.
Okay.
Yes, sir. Thank you,
Thank
sir.
you. Thank you.
So there was few videos
Sir,
which I wanted to present, but because of time constraint, I stopped it.
Okay, sir.
There are five videos is on the course about how it was done.
Sir, you can
how-
share with the groups in the group, sir. People
Yeah,
will come.
we'll share it
Yes,
with the
sir.
group.
We will
yes,
share.
yes.
Yes. Thank you,
Okay.
sir. Thank you,
Okay,
sir.
bye.
Thank you.
Thank you.
Good night. Good night.
Thank you, sir. Thank you very much, sir. Good night.